What we're going to do this afternoon is talk a little bit about integrating CVI principles across the team. So it's really important today to have people who actually work as team members as part of this conversation. So I'm Christine Roman, and we also have with us.
I'm Ruth Ann King. I work with West Virginia Sensibilities Project.
And what is your specialty? What is it that you do in that project?
I like working with the families and the other team members around children with significant disabilities, including the deaf blindness or combined vision and hearing impairment.
Perfect. And?
I'm Kathy Quisenberry. I'm an occupational therapist. I work in early intervention, and I also serve as a member of the West Virginia CVI Mentorship Project.
Perfect. Okay, so when we talk about integrating CVI across a team, I think we kind of have to start at the beginning, and if we can talk a little bit about the identification of these very young children who may have CVI. Do you think, first of all, that you're actually serving all the children who actually have CVI? Do you think identification, diagnosis is a challenge?
Go ahead.
I think it is for many people, because I think one of the challenges begins even before a child may be identified with concerns just in early intervention. I think parents might sometimes initially have concerns, and they go to their pediatrician and they voice these concerns like, my baby's not looking at me the way I feel like they should, or they don't, or I've had other children and they don't, this one is not responding the way my others have. And the pediatricians, a lot of times, I think they tend to pacify the parents and tell them, well, that's okay for some reason or another. Let's just give them a little bit of time, and we'll look at them the next time you bring them back, which typically is 3 months and sometimes 6 months. And sometimes that scenario replays itself.
And so do you think the wait and see advice is good advice?
No, I don't think it's good advice, because we all know that the plasticity in a child's brain is... we need to take advantage of it the earlier we can. And so even if a parent has a concern, I don't think it's an issue for the physician to explore that a little bit further. I don't see where that's going to hurt. Better to err on the side of caution, I think. And so if there is a concern, I think they should pursue it as quickly as possible.
I know on a state level that the identification has certainly increased a lot. With the Deaf Blind Project here in West Virginia, we had about 15% of our children being identified with CVI back in about 2003, and now it's over 60% of those children with combined vision and hearing impairment that have a diagnosis of CVI.
That's impressive.
I still think that we have a long way to go, and we can't stop doing all the work that we're doing, but I think with increased awareness, both on with the different team members, but also from the family perspective, that we're getting there.
That's a pretty big leap. Are there red flags that you would share with physicians, parents, other members of the early intervention team? Red flags that might indicate a child is more likely to have CVI?
I don't know initially when they start looking at the red flags if that's the first thing that might necessarily jump to their minds, only because I don't still think there's a huge awareness among a lot of pediatricians in what CVI is. However, I do think there are red flags that definitely pursue or warrant making referrals either to early intervention or to other specialties, based sheerly on the fact of the way a child should be responding very early in their life, just responding to their parents with visual responses by the age of many times 2 months, not even 3 months, looking and interacting socially. And when those things aren't occurring, I think it's definitely worthwhile to pursue as a reason why they're not.
Yeah, I would agree. And some of those, just sharing of the information of the birth of the child and some of that information that we then later gather in the parent interview. But often if just someone's listening, there are things that the parent or another family member is saying, or another person of another discipline might pick up on. So.
Well, and I think sometimes too you hear the parents say that they just, something in their gut told them something wasn't right. And I think you've got to trust that in a parent, because they know their child intimately, even from the first day.
So when a child is born with a medical condition that is associated with CVI, maybe they've had a perinatal stroke or asphyxia, or they've had a big bleed in their brain or a big chromosomal challenge, or perhaps they have a structural difference associated with hydrocephalus. All of those issues that relate to the sort of brain-based cause of CVI, I think might also be red flags that could be something that would help trigger kind of a question that the medical providers might be providing. I've also noticed that parents of kids with CVI, when you ask them later, when the child's 2 or 3 or 4, when you ask them later, was there a time you ever wondered if your child could see? They often go back to those very first months and say, when they were first born until they were 3 or 4 months old, really, I had that feeling, like you mentioned, in my gut that maybe they really couldn't see me. So I think you're right. There is something that just really triggers that. So diagnosis is kind of a big issue. Are there ever times when a child doesn't actually have the diagnosis, but the parent has reported to the team, I have these concerns, is there ever time that members of the team could provide supports or suggestions even before the diagnosis is in place?
There have been, and I think I see that as part of teams I've been on, especially in families who don't have a lot of resources, and the ability to see maybe even a specialist who might be voiced in recognizing CVI because they don't have the means to get there financially. And so by having team members in early intervention who do have some knowledge, some understanding of that, they are able to assist the families very early on, and even in locating resources to get them to see the people and the specialists that they need to see.
It is a challenge. Go ahead, Ruth Ann.
We certainly have that. One of the things that we have had to do in some of the more rural areas too is we've set up a system to take the services to them. We have something where we collaborate with Children's Vision Rehabilitation Project and our ophthalmologist that works with that. Sometimes if we know that a parent can't get to a larger facility and get the diagnosis, we can make arrangements to have them go a shorter amount of distance with that. Also, sometimes we make the suggestion that if they're taking the child in to a feeding and swallowing clinic or for some other thing, that we can make some arrangements to get an appointment at the same time for their convenience. But
That's great.
we know it's difficult, but we try to stress the importance as well.
And so who primarily provides that diagnosis in your state? Is it, one particular kind of provider that gives the actual diagnosis of cortical visual impairment, or are there multiple people that you feel can make the diagnosis accurately?
In our case, it's pediatric ophthalmologists, and it may be someone here in state, or it may be outside the state.
We do also have a couple of neurologists who are, I think, familiar enough with the diagnosis that they're comfortable doing that as well.
Okay. So tell me how you think this impacts parents. Do you think it makes a difference if they know their child has CVI or they just see their child as really complicated? Does it really make a difference for them to know if their child has CVI?
For some, I think it really does. I think that it opens a lot of explanation and opportunities for the parents who really want to make a difference and see their child progress developmentally, achieve different milestones, and just interact even with their families the way they'd like them to. As with any diagnosis or any child you come into, of course you have some families that it may not be as much a priority, but I think for the most part, the families that I've been blessed to interact with, it's been a huge enlightening factor for them and really been almost a turning point in the things that they do with their child.
Oh, I agree. And then you can really give the resources that they need that are specialized to that child's needs and help them to set up the environment and use some of the tools that we have available, get the training, meet other families that are going through the same thing. And I think that often for families, that's parents talking with other parents can be as helpful as anything.
Yes, exactly. Have you ever met parents or even other members of the early intervention team who perceive the child to be blind? Has that word ever been used?
Yes.
Go ahead.
Well, you explained that pretty well. They just felt like their child didn't see. And then all of a sudden, one day, there's something out of the blue, not a day they were least expecting it, that all of a sudden they see something that made them think maybe there is something there. But it seems like it's so often totally out of, totally surprised. They weren't expecting it. And usually it fits the criteria when you look at a diagnosis of CVI that falls within the CVI range in looking at that. But they typically, the parents don't know anything about that. So by talking to them, they can enlighten you, but you also help them pick out things that maybe they hadn't seen before.
I think that really shows up in the use of the parent interview too. When you go back and say, you know how you answered this question, or you told me
Right.
that story, and
Right.
then relate it to
Right.
the child's
It's
vision.
very validating, don't you think, to them to sort of be able to put those pieces together into something that now gives it some shape and form and a place to start. So so most of the children that we serve who have CVI, most of those birth to 3 children, have a whole team of people that work with them. Can you talk a little bit about that? In your mind, how many specialists usually work with kids with CVI?
I think it varies definitely based on the child's needs and what all is going on with the child. And in West Virginia, we're very fortunate because I think our early intervention system is a lot more diverse than other states. We meet the child's needs based on what they have, regardless of how many team members that might involve. So there are children that might have a physical therapist, a speech therapist, a vision specialist, an occupational therapist, a psychologist. I mean, it really depends on the child, and there's no set number that they have to have or no set minimum that it has to be. So, but many of these children, because of the nature of what's going on, they do have pretty large teams, and most of them that I've seen or been a part of have at least at the minimum had developmental specialists, occupational therapists, physical therapists, and speech therapists, and if a vision person is available, a vision specialist as well.
So Ruth Ann, who then takes responsibility to do the vision part, to do the CVI part of that? I'm sorry, not just the vision part, but the actual CVI, doing the CVI range, providing the modifications, helping support the family, talking to the team. Who in your state seems to take responsibility for that?
Again, it depends. We've done enough training that there are people in different locations of the state that are now feeling really comfortable and have done some reliability checks and so forth, and they can do that. A vision person on the Birth to 3 team, or our CVI mentors, like Kathy mentioned that she's one. We have 4 folks that are highly trained. Kathy being an OT, we have a developmental specialist and 2 TVIs. And we also have some CVI partners. So if the team is really in need of somebody else coming in, they can contact us and we can provide somebody to come in and do the assessment, have the child get a CVI range, write up a report, and talk to the team about some of their suggestions for intervention.
So it isn't always the teacher of the visually impaired that takes the lead relative to CVI on the team? Is that correct?
That is correct.
Yeah.
That is correct. And how has that worked for your state when you have teachers of the visually impaired, but they may not always be the person who has the greatest depth of knowledge around this topic? How has that worked in terms of the role sharing?
Well, they work in collaboration, and I think that that's really a good thing. They, like if Kathy's coming in, and then she will work with the person that on the local team is responsible for, as the vision person.
How's that been for you, Kathy?
Sometimes it's been challenging because in the early intervention system, I don't think we have as many vision specialists as we'd like to have. So there's a very large area that has to be served and not a large number of people to do that. And I think a lot of that is really relying on your team members and how accepting they are of the information and willing to take off and fly with it, because we do have very educated, intelligent team members across the board everywhere we go. So I think it really relies on the buy-in by those team members to how successful the suggestions are with the child.
How do you get that buy-in?
Well, I think the best way to get the buy-in is when they actually see it, because if they see it, and especially if it makes their job easier in some way, then they tend to believe it, and then they tend to buy in more. And I think the family can play a big role in that.
Absolutely.
If you have a family member who's very vested in wanting to see their child improve, then, and they are on board with the CVI recommendations from the beginning, then I think they hold their team members to the fire to help make sure that happens as well. In fact, I think oftentimes they become one of the most versed people on the team in terms of CVI.
Absolutely. Yes.
But then sometimes it takes some convincing otherwise, because it is a different way of thinking when you work with a child, and it is a different routine. And I think some of us become so ingrained in our routine, not out of lack of caring, but just because there's so many children you're trying to work with, and so many people you're trying to help, and adding new routines in is not always a comfortable fit. Not that it's a bad fit, it's just not a comfortable fit. So you're having to change the way you do things as well, and the way you think as well. So sometimes that can be a bit of a challenge.
Ruth Ann, do you see parents that kind of do their own research and already know what to expect before you show up?
Sure, and it's getting to be more and more like that, it seems like. And parents meeting with other parents and being in support groups, and they, I think that's sometimes too where the identification part comes back in too. They'll find another parent that's had a similar maybe birth history or experiences, and they'll be talking with them, and then they'll say, oh gosh, that sounds like my child, and they'll go on to get information and training.
So the parent is a really critical central force on that team.
They're the most, to me, they're the most critical, and a lot of times I'll even tell the parents that, truthfully, I bring you information, but it's what you do with it that is truly what's going to matter.
Okay.
Another thing too is sometimes it may be another family member. I've found that's happening a lot. Sometimes with all the complications that the child might have, the parent may not quite recognize it as much as somebody that's standing by a little bit
Yes,
and
yes.
supporting the family, and so occasionally it might be an aunt or a grandmother or
Absolutely.
someone else that really sees the importance of the vision and the need, and kind of takes that role as a family member.
Absolutely, I agree. I think sometimes families are so, they're just so bombarded with so many things. And I think we also have to recognize it very early on. I think a lot of families are just in a state of emotional upheaval. And they're adjusting to this new reality. And maybe they just can't see everything as well as grandma can, or an aunt can, or grandpa can, because they're just not there yet. You know, it's really can be overwhelming. It can be overwhelming. Do you see parents change in this birth to 3 time in terms of what they think is a priority? So it's been my experience as a developmental specialist that often families will sort of initially really want the child to eat by mouth, to learn to walk. And sometimes that vision thing just kind of hovers there, is not their main thing. And then you'll see as time goes on, they'll see the really profound impact that the vision piece has. Do you find that sometimes?
Oh, definitely. And I think you see that very clearly even in just the day-to-day things, because suddenly, like you said, the walking is important, but they begin to realize that without the vision piece of it, that may not be a realistic goal. So focusing on the vision really becomes central, and the other things seem to become secondary, because it almost seems like as they begin to work with the child on the vision, some of those other things begin to fall in place when you start to open those skills.
Right. So you mentioned that sometimes the things that you suggest makes the PT, OT, whoever's job a little bit easier. By easier, you mean that the child's more successful?
Yes.
And so can you give us an example of that, like in a PT activity?
A perfect example of a PT activity, I think, would be when you have a child who is in phase 1 and you're just wanting the child to lift their head up off the floor. Well, if they're in a home that's very well decorated, but that those decorations are multicolored, and there's a lot of beautiful things sitting around the home, it becomes a very, very busy place to look. And for that child, it's often very overwhelming, and so the PT's trying to get them to lift their head up to
Yes,
look,
yes.
but there's nothing there for the child to look at. It's too visually complex. So by modifying that environment where you provide a black background or darken the lights or position them so that maybe some of the decorations are behind them and just give them a single object to look at, then all of a sudden the child starts to lift their head. And it's a lot less effort, a lot less time, and a lot less frustration for the child,
Yes.
for the therapist, for the parent.
Right.
So that's, it really, I guess maybe to me makes sense. But it seems like a very easy thing to do to get the ends to the means.
And then the team members get so excited and the family members when they see that improvement in the child's vision. And I think once we begin to see those improvements in the child looking and learning more, that's when the team really can become motivated, and that's where it's a good place to really dig in there and provide more intensive training at that point and more awareness.
So the environment, birth to 3 is the home environment, correct?
Yes.
Sometimes it's a daycare setting, perhaps. There must be challenges related to the environment. As you mentioned, if the home is, really lovely but very busy visually, that can be a challenge. Not only do you, it seems to me, have to really hope the family you can support the family in creating a visually appropriate environment. But what about all those other therapists who might be giving a different message or just not giving the message that that's important? That can be a really difficult thing. I mean, talk a little bit about what you talk to families about and what you talk to other team members about, the PT, the OT, the speech person, about the environment. Then we'll talk a little bit about the actual materials.
I think it can be challenging because I think it's very important for families to maintain confidence in their team members, because when they lose that confidence, it becomes more challenging to expect them to do what we ask them to do. So for myself personally, I try not to contradict wrong information, but instead try to redefine that information a little bit. And for example, going into a home once where it was prior to bringing someone in concerned about vision, and the therapist had some knowledge, but there was everything that had been wrapped in foil. And so they had taken a little bit of information, which was, and that's better than nothing for the parent. There had been some responses, but we twisted that and started to talk about why something with color might be a little better for the child. And so I definitely feel like it's important not to undermine other team members to the families, and then to address the team members individually outside of that home, because unfortunately there isn't a lot of opportunity within our system to be able to work together, which I think would be wonderful. We are limited to 2 teamings a year with the whole team present, which is a challenge because then you have to take that initiative to do that outside of the time with the family. But if it's important enough that you want to see the child succeed, then it's important enough that you make those connections and work together to share information. And I think it's also important not to say you're wrong, not to tell team members they're wrong, but to maybe offer better suggestions on how it might be more successful. Because if they get mad, if they get mad at you for telling them that they don't know what they're doing, then they're less likely to
Right,
wanna work with
want to
you.
accept your future suggestions.
Exactly.
Yes, indeed.
Well, I don't have a great answer for that, but I do present more of a question that we get, and that is that so often it is, how are we going to provide this communication among team members and family members so that it's consistent on what strategies and interventions we're using with the child, and it can be tricky.
Yes,
That's
really
one of the
can be.
problems with the whole with the whole approach. One of the things we've been trying, of course, we've used all kinds of things, but is sharing in videos too of success or pictures, and a lot of the parents even are really good with showing what works and being the lead sort of on the team of the sharing of the communication and so forth. So
That's
it's always a
actually
challenge.
what I was thinking of after you said that is a lot of times you can utilize the family member in a wonderful way to share with the other team members what you've shared, because then you can also recognize if there's some generalization of that learning, and then if there's also been some carryover, because if they can share with the team members accurately what you shared with them, then you kind of have a better feeling whether they're doing what you hope you've shared with them to do.
So what if, so let's say, you've identified this baby, you've talked to the family, you've done a CVI range, you've evaluated the child's level of functional vision, you have an environment, a place within the home that matches their score, and you are providing, vision supports to routines of the day. Let's say someone like a speech or communication specialist decides that they have a very, really great suggestion for how to help promote maybe expressive language, but it doesn't match that child's CVI range score. That could also happen with an OT, a PT, another colleague in vision, or, it could. So let's say a team member, and here's an example. Let's say we're trying to teach this child a certain concept, and the child, the pictures have been brought in for the child to use to try to make some decisions or make some choices about. But you have assessed the child and found that actually anything in two-dimension is really difficult for the child to even perceive, let alone discriminate. How do you meet that challenge?
One thing I would encourage anyone to do who initially evaluates that child is to clearly spell out in their initial report that until the child is functioning at a certain level on the range that they shouldn't introduce two-dimensional material, so that they get that information from the beginning. But that doesn't always
Correct.
work. I think sometimes you don't find out about that until after several visits have been done. The family may not think to share that with you, or they've just introduced it and it's been several days since the therapist was there, so they don't necessarily think to tell you about that. And so usually the thing that I've seen team members do is talk to other team members about, or the family, how successful that has been, and then collaborate with that individual and ask them, how successful has this technique been for you? What do you see are the strengths? Where are your challenges? And then offer, hopefully, some input that might be received well as to some ideas that they may try to modify it a little bit and try it and see if it might be more successful. Keeping in mind the initial goal that they are wanting to achieve in the first place, so it still remains, it still belongs to them.
I agree, and I think too, just kind of that, let's try this,
Yes.
and bring in some additional materials and say, let's just see and present the information to the child and kind of take a look, an informal look and observation, and it's all in the teaming and personalities and all that.
Yes, it is.
Play into it.
So maybe perhaps these parents have been told by one of their team members that your child has seizures and really can't progress visually. Your child is too cognitively impaired to understand what I'm trying to teach them. Your child has too many severe considerations. Your child is too medically fragile to make progress visually. Do you contradict that? How do you advocate for that child?
That's a challenging question.
Yes, and I think you should just answer it from your heart.
Well, what I tell the families is that I don't believe any of us know the true potential of the child, and only time will tell. I don't think any of us predict the future. So there's no true way to know. There's been many children I've worked with over the years who have been told one thing or another, and they've exceeded those expectations 10 times over. So that we need to give the child a chance to truly show us what they can do.
I'd go back to the impact of vision on learning. Get out the information, and we train and train on that. But I think, people just in general don't really understand how much we learn from our vision. And so I think going back to the basics with that and just...
Right. I often say until a child has access to their world, we don't really know how they learn, what they can learn, and so forth. And that vision can sometimes create a situation of almost deprivation, especially if the child can't move on their own, they can't speak, they have difficulty, with even head control, that we don't really have. This child has not been given enough information yet for us to really make a judgment about that. And that's kind of a way to have a better idea about vision and about that child's potential. So, do you ever make predictions with families or team members? Do you ever say, I think, this child will eventually be able to? Is there anything you ever set forth with a family or with a team that gives them sort of a path and says, to say, this is my expectation, this is what I think, this is where I think, do you ever take that risk and share that? And what if a parent asks you? I know I've been asked many times. What if a parent asks you, the child's, a year and a half old, will my child ever read?
We have enough data collected from all of the CVI assessments that we've done over time with a number of children to be able to at least give an indication that we can expect improvement.
Yes.
We should expect improvement. And that provides hopefulness, and that creates good energy with the team members and families.
Yes.
So
Right.
that's one way to go about it.
That's great to have those data.
I'm not that willing to go that far out to predict the future, but the one thing I will tell families is that I've been very blessed, and all the children I've worked with who have CVI, that there's not one that I've worked with that I haven't seen progress of some sort. And so that's my expectation. Until there's one out there that proves me wrong, I have no reason to believe that we won't see some kind of positive change, because all of the children that I have worked with have shown me that, and it's one of the most amazing things I've ever seen.
It's kind of a very hopeful thing to be able to share information with families that actually suggest progress, that says, this is actually something that we can support in a way that will actually help this child have increased use of vision. It's a wild thing to say, really, Those of us who've spent our lives in vision education still kind of trip on those words because it's not what we're used to saying. But families have reported to me that it makes them feel so optimistic to know there is something, of all these things they're waiting for, of all these seizure medications they're hoping will work, of hoping that this G-tube helps put weight on their child and so forth, that there's this one thing that they can actually dig in with and see some real progress with, which is very optimistic, and it's a very special place to be in a position to offer those things. So let's talk a little bit about transition. So you have these children birth to 3, hopefully you've identified them very early. I don't know, do you have an idea about how old children are when they're first diagnosed with CVI in your state? Is there kind of an average age?
I don't know of an average. Of course, we want them to be identified as soon as possible, but that certainly varies.
It does.
I think it's very dependent on the families as well. The support they've had from their pediatricians,
Right.
the encouragement they've had, and this ones, some of them are just, I'm tired of waiting and I'm going to refer them myself and see if I can't get some answers myself. So I haven't seen a typical average age, but I have seen the age get younger, if that makes sense.
Interesting.
Closer to the 18-month range, where I see families bringing up concerns now versus closer to maybe between 24 and 30 months when I first started
Great.
working with these children.
Great. And I think it'd be interesting to also just share information that in the state of West Virginia there is a very solid system in place to help keep track of kids with CVI once they're identified, to actually help families with that identification process, then to keep track of them, monitor them, and even keep track of their CVI range scores over time, so that there's a sense of consistency across. I think that the state of West Virginia has been unusually successful, especially when you mentioned the number of kids that you've seen with dual sensory issues, both combined hearing and vision loss. So now maybe the child's 2 years plus, and you know that year between 2 and 3 is a year to think about transition. What steps might you take to help with a smooth transition? Because parents of children with CVI and other parents who receive early intervention are not always prepared for what is facing them once they transition from the IFSP to the IEP process and all the things implied with that. So how do you prepare a family? How do you prepare the team? What do you do around transition?
I think our system is very blessed discussed with the practitioners, and then the practitioners almost start begin to think of transition from the day they meet the child, even if the child is very young. And I think gradually over time, that is a process that we discuss with families, bringing in a little bit of information and a little here and there, so as not to just feel like we're throwing them out to the sharks.
Like, what would some of that information be?
Like when we're working with maybe an 18-month-old and they begin finally to walk. Well, we talk about, won't this be exciting? So now when they're in school, how they're going to be able to interact differently with their peers and how they're going to be able to play with the other children on the playground. So very early on, we look at the context of the things the child is doing and begin very early talking about when they go to school. It's not ever, I don't feel like on teams, it's not a question of if they go to school.
Right.
Because I think we have a very good preschool program. It's when they go to school. And we want to make sure steps are in place to help ease that transition. And one of the things that needs to be done for the transition process is if we don't have a diagnosed condition, try to facilitate in any way possible getting to someone who can address those vision concerns, because that's one piece that could be lost in the transition if
The
we don't
diagnosis
have
of CVI.
of CVI, yes, before they transition in the school system, because if they don't have that and there is no other diagnosed vision condition, then they won't receive those services after transition. And that's very important, because that's a whole different world the child will be walking into.
How do you prepare? What do you share with families?
Well, I'm not a direct service provider, so but speaking from the from a state agency, state project
Absolutely.
perspective, we know that information transfer is sometimes great and sometimes not so great. So, just from the Deaf Blind Project perspective, one of the things that we're doing now is creating for each of those children on our census something called Sensibilities eFolio, where we have a password protected site that carries all this information, and we get to work with the children birth to 22. So this warehouse cabinet of information can pass from the birth to 3 team through to the school team and later to post-secondary transition, hopefully. So.
And do you feel like the same risk, the same concern exists for kids with eye disorders? Or do you think it's a greater risk in terms of the risk that the child might not be, picked up for vision services or might not be identified as having, these real specific CVI needs? Is it different for kids with eye disorders versus CVI?
I think it is. Personally, I think that that's more clear cut and it's an easier diagnosis, and there are more people who identify those particular eye issues or vision disorders. I don't think with the number of ophthalmologists out there who really aren't even that familiar with CVI that it's picked up as easily, because you can only truly go to a few people who are voiced in making that diagnosis, and it might be misdiagnosed or diagnosed incorrectly. And so I do think that eye conditions are more easily identified by a broader range of people, which increases the access.
Same?
I agree.
Yes.
Yeah.
So do you ever, has it ever been the case where a child may or may not be identified as having CVI, could happen either way, and that their behaviors like staring at lights or having, only wanting to maybe interact with familiar objects or not being able to look at faces, maybe not following a point, not seeing things at distance, liking things that move. Have you ever seen that some of those behaviors, those characteristics are interpreted differently for some children in birth to 3? Does that happen?
I think sometimes it might initially, until conversations begin with the families and the practitioners, especially practitioners who've been in the system longer and are more familiar with CVI. Because I think once they start that dialogue with the families and they start hearing some of the other comments that have been made, like they really, really like to look at this one particular shirt that I like to wear. They're very fascinated with this. Or, when they were little, like you said earlier, they really didn't look at anything for the longest period of time, because even a child with other diagnoses that you might find, you don't see those typical responses of not making that initial eye contact that early in life. So I think that red flags start to come up with a lot of practitioners who then start hopefully pulling in other team members. I actually had that happen recently with a child.
So there are some diagnoses such as autism, that could actually be somehow combined with or confused with, and it's something we have to really be very astute to and really advocate for families, which leads me to something that I would, kind of like to close with, and that is, how do you see your role, or well, let me ask you, what do you think parents want from us as professionals? Whether you're the speech person, the OT, the PT, the CVI mentor, the administrator, what do they want from us relative to this child's visual impairment? And when I say us, well, go ahead.
Oh, go ahead and say what you say.
Well, what I'm really getting at is advocacy. That's what I'm really getting at. That the person who really knows this child's CVI, I believe, stands in the center of the core of what could affect this child's learning. And so we are really I think we're obligated to reach out like spokes from that core, to reach out to the speech folks, to the OTs, to the PTs, obviously to the parents, to all the providers, to the administrators, to the physicians, to help clarify, understand, and spread that information. And I think advocacy is critical to the success we have with kids, especially in transition.
That empowerment of the family and the giving them the accurate information and continual training as their child progresses and is just imperative.
It is.
I think we bring hope. I think hope is key. We talked about earlier for the family. I think if there's even just a bright glimmer of hope, that they will fight for their child, and I think they're looking for people who are going to fight right along with them for their child. And I think sometimes that you're not necessarily, as the vision or the CVI person on the team, depending on who the practitioners are, you may not be the most liked at certain points in time.
Really?
No. But I think in the end, when you can show results, I think you'll gain respect regardless. I think that it's not always an easy place to be, but I think that everybody who's doing this job is truthfully there for the same reason. They're there for the children, and if we can keep that in perspective, that the other things may be a bumpy ride, but in the end, we can get to where we want to be.
Ruth Ann, as a person who interacts a lot with parents, have you heard parents have you ever gotten a sense a parent has an advocate in you or in a member of their team that will kind of really help carry their torch for what they want for their child and what that might mean to them?
Oh, sure. And I think that can be people of varying roles.
Absolutely.
But I think that there's always some team member that has taken the flag and wants to roll with it.
Anything else you would like to mention or talk about relative to the really critical period of time, that birth of 3 early intervention time and CVI?
I just think what you just to reiterate what you just said, it's such a critical period of time, and that one of our obligations is to continue to try to educate not just families, but the service providers, the pediatricians, the people who see these children from day one, down to even at times the doctors who see children in the hospital who may not be their own, that if there's a certain pathology that's there, that the child presents with even at birth, that these are things that you need to put in the back of your mind somewhere, because we can catch them early. We really can.
Okay, thank you so much.